Hi, my name is Jonathan Finoff. I'm going to be demonstrating a live ultrasound examination of the lateral elbow. I don't have any disclosures, but I do have a disclaimer. This presentation is not meant to be a comprehensive review of this topic. Our objective is to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships.
All right, now we're going to do a lateral elbow examination, and so here on the left of the screen is going to be proximal, and the right of the screen is going to be distal. And so this is the lateral epicondyle coming down, and you want what we call the ski jump image. And so here we've got the slope of the ski jump, and here is the jump itself. And so this is the lateral epicondyle, and this is the origin of the common extensor tendon. And then right here is going to be capitellum, and this is radiocapitellar joint right here. This little piece of tissue right in this area, that's the lateral synovial fringe, which is essentially a placal remnant of tissue that sometimes it's normal in most individuals, but it can get caught in the joint and it can snap and become painful. Regardless, what we're looking at here predominantly is this common extensor tendon origin. So you want to look for enthesophytes, cortical irregularity, see how nice and homogeneous and hyperechoic and fibrillar this tendon looks. If somebody has pathology, it's going to be hypoechoic, thickened. There's going to be irregularity, sometimes calcifications. There will be hyperemia in the area. So you want to look for all of that type of pathology. But this looks really good. And as I come down further distal, you can see here's the radial head. Sitting on top of the radial head right here is the annular ligament. So here's the annular ligament extending about to right there. If I come back more proximal again, and sometimes we can get a better view of this, sometimes not, but essentially the deep 50% of the common extensor tendon origin region, or this lateral epicondylar region, is going to be radiocollateral ligament origin. And you can see some fibers here and blending with this annular ligament here. So this is radiocollateral ligament coming off of this area. And it's either the deep 50% or deep 30%. So 30 to 50% is going to be your radiocollateral ligament. As I come across to the radial head, you can pronate and supinate and look at the radial head underneath the annular ligament. You can come down a little bit distal and look at this radial fossa area. So we talked about that in the anterior elbow examination. And again, you can pronate and supinate and look and see if you see any fluid in that radial fossa, or excuse me, in the annular fossa. So I'm going to come back up, and in the area, I'm going to decrease the depth. The common extensor tendon origin, you want to make sure that you scan all the way to the anterior margin, and you want to scan all the way to the posterior margin and make sure that there's no pathology along the entire course of that common extensor tendon origin. Now I'm going to look at that in short axis. So I looked at it in long axis. Now I'm going to look at it in short axis. So anterior is going to be on the right of the screen. Posterior is going to be on the left of the screen. So I'm going to actually start a little bit higher up in the elbow here, and kind of at the mid-arm region. And I'm going to increase the depth here by a couple of clicks. I'm going to decrease our 2D gain, change the focal zone. So right here you can see the radial nerve. So this is going to be posterior, and right here is going to be anterior. And as I glide distally, you'll see the radial nerve moving from the posterior compartment to the anterior compartment of the arm. And in that same area, and I'm going to increase the gain a little bit here, but in the same area where the radial nerve goes between that intermuscular septum, that's going to be your origin of the brachioradialis. So right in this area, this is the brachioradialis muscle. So I'm going to glide distally, and here's that brachioradialis muscle right here. But I'm also going to keep my eye right over here. Depth. I'm going to change the focal zone. So here again, this is all brachioradialis right here. And as I go distally, right in this area, so right here's brachioradialis. As I go distally, you see how there's another muscle coming in? So here's brachioradialis, again going proximal. And right there is another muscle. That's going to be the extensor carpi radialis longus. So now, and here is, it's poorly defined, but right there is the intermuscular septum, or the fascial plane, I should say, between the extensor carpi radialis longus and the brachioradialis muscle. We come all the way down to lateral epicondyle. Once we get to lateral epicondyle, I'm going to center that in my screen, and I'm going to glide off of it. And so the tendon right here, this is the common extensor tendon origin. So you want to look at that in short axis. Right here we're going across the radiocapitellar joint. Here's the radial head. Here's that common extensor tendon origin still. And so essentially you want to look at all of these tendons in orthogonal planes. So this is the short axis view of that common extensor tendon origin, and we previously looked at the long axis view, and you want to confirm pathology in two orthogonal planes. So now I've looked at brachioradialis, extensor carpi radialis longus, common extensor tendon origin and long and short axis, radiocapitellar joint. Now we're going to look at that radial nerve a little bit more. So I'm going to increase the depth here a little bit, change the focal zone. Right here is the radial nerve, and I'm going to put our model's hand in a supinated position. I'm going to increase the depth another click here. So I'm looking at that radial nerve, and so on the dorsum or lateral aspect of the elbow here is going to be brachioradialis. Medial aspect here is going to be brachialis, and so the radial nerve sits in between the two. And right here the radial nerve is one nerve, and right it's dividing into the superficial and deep branches. Again, I'm going to change the depth, change the focal zone. We're going to follow that deep branch right down here. I'm going to decrease the gain. There's that deep branch right there. It's coming down, and right there it just went underneath the arcade of Frosch. And that's a fibrous tissue at the proximal entrance to the tunnel that goes in between the two bellies of the supinator. And so the deep branch of the radial nerve, as it enters that supinator muscle, becomes the posterior interosseous nerve. I'm going to increase the depth here a little bit. And now I'm going to pronate our patient's arm. I'm going to center posterior interosseous nerve, and now I'm going to glide distally, keeping on top of that posterior interosseous nerve. We're going to come all the way around. And right here you can see it coming out from between the two muscles, or the two heads of the supinator, into the dorsum of the forearm, where it will innervate the dorsal forearm musculature. All right, now I'm going to come back up proximally, follow that deep branch all the way through again, and come out on the volar aspect of the forearm. So here's the superficial branch. And here, that superficial branch, I have it centered in the forearm, so superficial to it is going to be the brachioradialis muscle. So you can follow that all the way down to the wrist. One thing that you can do while you're looking at the lateral elbow is stress the radial collateral ligament and look for integrity of the lateral collateral ligament and see if there's any laxity in the joint, the radiocapitellar joint. So here again, I'm getting that ski jump view of the elbow. So we remember that the deep 30 to 50% of this is going to be your radiocollateral ligament. So here's the radiocapitellar joint. So I'm going to put the patient into a fully pronated position in their forearm. I'm going to then put a varus stress on their elbow. You can do this. You need to make sure that there is some flexion in the elbow because the olecranon will lock into the olecranon fossa if you have them in full extension. So you want probably between 20 and 40 degrees of elbow flexion, and then you want to have them in a fully pronated position. And you can see here, as I stress the model's elbow into a varus stress, that there is no significant laxity and no separation between the radial head and the capitellum. You also want to make sure that the person doesn't have any shoulder instability while you're doing this, just because this puts a lot of torque on the shoulder, and while you typically think of shoulder instability in a abducted and externally rotated position, with people who have shoulder instability, anything where you're cranking on their shoulder while you're testing their elbow can be uncomfortable. So you can certainly stabilize their shoulder or have an assistant stabilize their shoulder while you're doing this test. And that covers the lateral elbow examination.